All right, let's jump right in. We're going to break down lower extremity arterial disease in a way that is absolutely perfect for your board review. We're talking the high-yield facts, the classic patient presentations, and all the buzzwords you need to know to crush these questions.
So you get this classic question, right? A patient comes in and their leg hurts when they walk. The question is, where's the blockage? Now, it seems so simple, but the answer to this one question tells you a massive amount about what's going on and what that patient's future looks like. And trust me, by the end of this, you are going to know exactly how to nail this diagnosis. So here's our roadmap for this. We're going to start by mapping the anatomy, then we'll figure out who's at risk, talk about where and when it hurts, how to confirm the diagnosis, what to do to fix it, and finally, we'll cover the really important stuff, the outcomes and complications. Okay, first things first, we have got to map the territory. You can't find a problem on a map you don't understand, right? So let's break down the arteries of the leg into 3 main zones, and we'll start from the top and work our way down. So, Zone 1 is the aortoiliac region. This is the big stuff, the main pipes, We're talking about the end of the aorta and those massive common iliac arteries that split off. Think of this as the superhighway bringing all the blood down into the legs. Next, we move down into Zone 2, the femoral-popliteal region. Now, this is a big one. This is the main road that runs right through the thigh, the superficial femoral artery. And here's a super high-yield pearl for you. This is the single most common spot for atherosclerotic blockages. Definitely remember that one. And finally, we get down to Zone 3, the tibiopedal region. If the first 2 zones were the highway and the main road, think of this as the local streets. These are the smaller arteries below the knee, the tibials, the pedals, that deliver blood right to the doorstep of the foot. All right, so we've got our map. Now let's talk about the drivers. Who gets these blockages and where do they get them? Because this is where the classic patient profiles come in, and you just know this stuff is going to be on the test. Okay, lean in for this, because this is pure gold for your boards. You see a question with a 55-year-old male smoker who's complaining of butt or thigh pain when he walks. Your brain should immediately scream aortoiliac disease. You see diabetes in the question stem? You better be thinking about blockages way down low in those tibiopedal arteries. These buzzword connections are absolutely key. All right, now for the cool part. This is where you get to be a real detective. The patient's story, the history, can often tell you exactly where the problem is long before you get any fancy tests. It really is all about listening. So the classic symptom we're looking for is claudication. And what does that really mean? It's pain that's reproducible. The patient says, "Doc, every time I walk about 2 blocks, my calf starts cramping up. And every time I stop, it goes away." That right there is the textbook definition you need to recognize. And here is the golden rule. You gotta remember this. The pain is always one muscle group below the blockage. It's that simple. So if there's a blockage high up in the aorta or the iliacs, the pain is going to show up in the buttock, hip, or thigh. If the blockage is in the thigh, in the femoral popliteal arteries, the pain is going to be in the calf. See how that works? Okay, but then there's something else, and this is a major red flag: ischemic rest pain. This is a whole different beast. This isn't pain with walking. This is pain when you're just lying in bed. The blood flow is so bad, the foot is literally screaming for oxygen. Patients will tell you they have to hang their leg over the side of the bed just to get any relief. When you hear that story, you need to think, this is an emergency. This is chronic limb-threatening ischemia. So, the history is pointing you in the right direction. You check their pulses and they feel weak. You're pretty sure you know what's going on. But how do you prove it? How do you confirm the diagnosis objectively? Enter the ABI, the Ankle Brachial Index. Honestly, this is one of your best friends when it comes to PAD. It's simple, it's not invasive, and it gives you a hard number to work with. It's a fantastic, elegant tool. And there's really only one number you have to burn into your brain: less than 0.9. If that ABI comes back less than 0.9, you have just diagnosed them with peripheral artery disease. Done. It's that straightforward. Now, if that number is really low, like less than 0.4, that's when you get really worried. That tells you the disease is severe. This is the ABI level you'd expect to see in a patient with that scary rest pain we just talked about. So what's normal? Well, anything between 0.9 and 1.2 is generally considered okay. But, and this is a big but, you have to watch out for patients with diabetes or chronic kidney disease. Their arteries can get as hard as a rock, literally calcified, so you can't compress them properly and you might get a falsely normal or even a crazy high ABI. It's a classic clinical pitfall. Okay, Diagnosis confirmed. We know there's a problem. So what are we going to do about it? Well, there's a pretty clear ladder we climb for treatment. And spoiler alert, surgery isn't the first step. The foundation for treating any patient with PAD, I don't care how bad it is risk factor reduction and exercise. Period. We have got to get them to stop smoking, and we need to get them on a structured walking program. Everything else, the meds, the stents, the bypasses, that all comes later for people who really need it.
When we do add medications, we're really trying to do two different things. Goal number one, and this is by far the most important, is to protect their heart and their brain. That means an antiplatelet, like aspirin, and a high-dose statin. Goal number two is just to help them feel better, to help them walk farther without pain. And for that, we have a specific drug called cilostazol.
So, last section. Why do we care so much about all of this? I mean, it's just a leg problem, right? No, absolutely not. And this might be the most important point of the whole talk. Peripheral artery disease is never just a leg problem. It is a giant flashing warning sign for a whole body problem.
Look at this number, 25 to 40%. That's the chance that a patient who shows up with symptomatic aortoiliac disease will be dead in 5 years. And they're not dying from a bad leg. They're dying from a heart attack or a stroke. Their leg pain was just the tip of a very, very deadly iceberg.
I mean, the risks are just everywhere. Having PAD means you're way more likely to have a heart attack or stroke down the line. Heck, even the surgery to fix the leg has a pretty big risk of causing a heart attack right then and there. And of course, there's the leg itself. You can get terrible ulcers, gangrene, and for those really sick patients, especially those with diabetes, the risk of needing a major amputation is it's heartbreakingly high.
So what's the big takeaway here? What's the one thing you should remember from all of this? It's this. The fancy surgeries and the high-tech stents are amazing tools. They really are. But they are not what saves the patient's life. The real key to managing PAD isn't found in the operating room. It's found in prevention. It's found in aggressive, relentless risk factor reduction. You want to save this patient? Get them to stop smoking, control their blood pressure, manage their cholesterol. Because treating PAD effectively means you have to treat the whole patient, not just their leg.